Good morning, everyone. Hi, I'm James Goodyear, Director of Strategy, and welcome to this week's Report Out. We've got a really great agenda today, and so without further ado, I'll hand straight over to Bev and Nalini to tell us about the Start on Time Kaizen event 30-day Report Out.
Yes, so this is our first start project in paediatrics, and I'm the lead along with Nalini, and Jonathan is our sponsor, and Claire Elliott, our business manager with RAM, part of the QI team. So our plan was, this is our target progress report to give you some sort of baseline of what we were working with. So we started this project on the beginning of June, 10th and 11th of June, and we looked at the number of late starts, and our baseline was 11.5% of 0%. We monitored 2 lists at the beginning, 2 ENT lists, one of which was a late start. That was 50% our target, our results. And at 30 days, we have 3 lists out of 13 that have started late. So that's 23%. So we're not there at the 0% there yet, but we are making changes along the way with the project, which hopefully will give those marginal gains in the future. We've got, we're looking at the lists that overran, because obviously if we don't start on time, the potential is that we're finishing on late. The baseline is 57%. At 30 days, we've had 2 of 13 lists that have overran, which is 15%. So we've made some changes there and some improvements there. The 50 is focusing on the scheduling, getting our scheduling right. We can then, all the other things should fall into place if we've discussed everything at scheduling. So we haven't really seen very much change there, but we are working on it with everybody, trying to improve the engagement with that. And our quality, the list order is first patient needs to be on the list, and 28% is our baseline, and 1 out of 13 lists during this trial period where we changed the order of the list for a clinical reason, which is 7.6%, which again is a significant improvement in what we've been doing over the past month. So hopefully that gives you some sort of understanding of what we've tried to do and what we have achieved so far. We've identified that we've got some marginal gains there. What went well for us? Well, the theatre team and the anaesthetists have been given the opportunity to influence the process, and we're regularly discussing the reality, and the staff are offering us solutions to challenges that they face on the day. It's given us the opportunity to look at what are the challenges, wider picture, and everybody feels as though they've got that engagement and that buy-in, if you like, within the theatres and anaesthesia CSU. We've actually introduced a first patient meeting on the day before. That's at 2:45. We are mirroring what they were doing in neuro, and that seemed to be working well. So at 2:45, the day before our lists, we meet and we discuss the first patient on at the minute, just the ENT lists and one of the surgical lists, because we've got buy-in from those 2 specialities. That allows us to see, have we got a day case first? Is it a non-complex patient? Both of those things help us to be more efficient on the day, not waiting for bed allocation. We know what we're up against and we can get started straight away, and everybody knows the expectation of that first patient. So that's what's going well at the minute, but we're working on other things. So the aim was to get the patient into the anaesthetic room or the aim is, should I say, the patient in the anaesthetic room for 8:45. There's lots of challenges and mitigation that we've got, but here as just a list of some of the things that we've identified that we are picking out ways of improvement for each of these. So pre-assessment is variable at the minute. It's not, we don't pre-assess every paediatric patient at So we need to be able to incorporate that somewhere along the ways of working. The job plans and shift patterns of the team and ESA team don't really align with the prompt start, because it's an 8 o'clock start for many of the staff there, and between 8 o'clock and 8:45 there's an awful lot to do. But again, it's about working out how we can do that efficiently. The number that's on the list varies, so it could be one patient, which is easier for the team. There's only one patient to see from an anaesthetic point of view. There's only one patient to discuss at team brief. So that's more efficient than having 5 patients to see and 5 patients to discuss. Ward level issues, the location of the ward in relation to theatres, it's on the floor above. IT support, so we've not, a lot of our documentation is on are electronic now, so it's whether we've got that IT infrastructure to help us, iPads, etc., and staffing levels on the ward are not sufficient to, in the long term, escort 7 patients to theatre all at the same time. So we've got some issues there to work with the paediatrics, the children's CSU. Portering service, we did have buy-in from one of the porters there, the lead for the porters, and we've worked with them, but the portering services again are limited for to be able to support start in all theatres at 8 o'clock in the morning. Theatre equipment stock levels, we've had some issues with kit that's broken down and scheduling that's not highlighted, different people needing different bits of kit, plus we run the acute service, so sometimes some of the equipment is needed for acutes and also for the elective lists, but we're incorporating new ways of working there. Timely bed allocation, we have that 8 o'clock meeting to establish whether we have beds to go ahead for the inpatients, and sometimes that we're relying on step downs on the wards to allow us to allocate appropriate beds, which again, if we do a day patient in the morning, then that's first thing, then that's better for us. We've got time to do those things. Poor communication, we established that we need to be evaluating the progress and updating the teams, but because they're all on different shift patterns, they don't always get that message in a timely manner. So we're looking at ways that we can deliver those updates in a safe and consistent management. And we need buy-in from all the specialities to allow this to work efficiently and safely, and deliver a better service for our patients. So Nalini, I think you were going to talk about the actions and the outcomes, were you?
We need a robust review of case mix at scheduling. Currently, GERF proposed that we have a 642 rule in place to ensure that scheduling is robust. So we are working on getting better engagement from all stakeholders to follow the scheduling weekly timetable and confirm the first case as listed the day before. The team brief, the timing for team brief needs to be agreed with the team, because again, there is variability as to what time staff are expecting to brief at. So the large consensus engagement work that we've done both with the theatre teams and the anaesthetic colleagues is that the team brief will happen at 8:30, and then a discussion will be had amongst the team if the first patient that's been identified is fit to be sent for. And at the time, we would identify who would collect and escort the patient to theatre. And before the entire team brief happens, the first patient will be sent for. We would also make sure that we have portering support required if we need a patient to be transferred on the trolley. And we have made sure that we collect feedback from colleagues working on the coal phase, act on those feedback, and keep the team updated as we progress through this improvement cycle. So we ensure that the debriefs are accurately documented on the theatre management portal. So this can then be accessed by us retrospectively to ensure what's worked and what's not worked, and then allowing facts to influence future plans. Bev, do you want to continue?
Yeah, I'll pick this one up. So what would we do differently? So we had a 2-day meeting with the Leeds Improvement team and representatives from all disciplines that were involved in this project. And then on the 3rd day, we started this trial. And we have had some pushback, and we have had some confusion and a little bit of negativity. However, I think if we did something different in the future, I think we would allow more time to put the plan out and communicate the plan before we actually started the trial. We've established that the key learning is communication's key to a positive and a productive outcome. Our next steps are to improve engagement. So it's an ongoing process. We're giving feedback on a daily basis, and we're discussing with the teams to see what the changes, what necessary changes are there, and how we can implement them. The staff have asked for something written down, so written instructions of the structure rather than the verbal communication. So we've allocated a notice board to put this information up so that everybody, if they're not on duty on that particular day, can see that, and they're not reliant on opening up an email to gather the information. And we're addressing some of the quick wins. So we're improving scheduling, and we're moving on making changes there. We're discussing equipment needs and avoiding clashes between the specialities at the day, meeting on the day before. So we're not just looking at confirming the patient, we're looking at whether the equipment's going to be available and if there's any clashes there. So we've got lots of things to do. We're still positive, we're still driving this. We just what we're trying to do aligns with the 7 commitments of patients waiting and the Leeds Way values of being patient-centred, and I think it's going as well as we expected it to go at the moment. Thank you.
Brilliant, Bev, Lily, thank you so much. As you say, really important issue that will contribute to reducing waits for patients. And I love your learning around communication being key and the way that you're using your debriefs to think about what changes you can test next. Really well done. We'll have time for questions at the end, but we'll move straight on to the next report out from Jaya and Nick on the fractured neck and femur pathway.
Hello there, I'm Nick Freeman, and Jay is going to speak after me. So we're looking at our 60-day report out for preparing a patient for hip fracture surgery. We didn't actually do a 30-day report out because we realised the mammoth data collection was individually too challenging to do. So we have got one of our orthogeriatric middle grades to spend a week collecting the data. So that's where we've derived it from for this report. So if you look at our RPIW targets on the table to the bottom left there, they were to ensure that surgery for the first fragility fracture, hip fracture patient on the list starts on time, and consistently deliver surgery for patients within 36 hours of admission. And this is a key national best performance target, best practice tariff target rather. And also we wanted to reduce the frustration of the staff in the process. So this is our target progress report. So looking at ensuring we start on time, this is numbers 1 and 2. So we've succeeded in number 2, we've succeeded in ensuring the team brief in theatre occurs at or before 8:30. But then the patient is collected from the pre-wait area and brought into the anaesthetic room. However, this shouldn't really take more than a few minutes. And as you can see, we could still have a bit of a lag for that. One patient didn't come into the anaesthetic room until 9 o'clock. And another problem we've got is that not all checklist items are complete. It varies on which metric we use, but the 60% is having everything complete without a scramble in the morning for the patient to come to theatre. The other important one, which comes with a lot of money, is lead time patient wait for surgery. So that needs to be within 36 hours. Our target is set at 85% of patients for this because it's not possible to get 100%. The best centres get 80 to 85. Unfortunately, our performance has not really changed over the last 60 days. It's been quite up and down, as you can see by the various percentages of patients getting to surgery within 36 hours. The best week in our data capture was actually the week before we started the RPIW, and that was 54%. And the worst week, which didn't fall into any of the metrics on the screen, was the week of commencing 10th of June, where we achieved 0%. And therefore 0 best practice tariff, and over £21,000 was lost because of that. Our overall best practice tariff was 21% in June, whereas the best centres, as I say, achieve 80 to 85%. This is a graph from the National Hip Fracture Database. The shaded area at the bottom is all our care meets best practice tariff, and there are a variety of components in this, but as you can see, the prompt surgery line closely follows whether or not we achieve this or not. So the next thing was we wanted remove staff frustration and improve morale. Our starting morale was 9% of staff felt great. At 60 days, 0% are feeling good. We had a staff survey was issued using Microsoft Forms, 20 responses with a good spread of the MDT team, and the percentage was calculated on the number of responses that were using the words empowered or valued from a drop-down menu. 15 felt frustrated and 5 felt okay. We had slightly better success with the junior doctor survey and their experience as we introduced the Padlet as an information sharing tool. Unfortunately, the Trust is trying to withdraw Padlet access now, but for the time being, hopefully we'll be able to keep it. So under 5 out of 10, so 10 was feeling great about working in the department in relation to hip fracture care, and 0 was feeling poor, and we got 4.75 out of 10. However, from a morale perspective, 50% were positive. We only had 4 responses, which might indicate engagement with this staff group is low, but 2 felt okay, and 2 felt frustrated and 2 felt good. They liked the Padlet. They thought it was easy to use and clear and easy to find information, although sometimes with poor Wi-Fi or mobile data, they found it difficult to get on to the network. The electronic clerking, they liked compared to the paper. It doesn't get lost. It can be completed remotely, can be referred to later. However, it has too many sections to complete. Just one more comment on that. Although from a sustainability perspective, going electronic means we save paper and £1.17 per booklet not being used. The themes we had from the staff survey in general were, because this was a free text option, patients not ready on the ward, too many list changes and waiting for kit for complex cases leads to a delay and downtime, and that we need wholesale changes, including dedicated hip fracture surgeons, anaesthetists and all-day lists, and non-hip or non-fragility fracture cases are listed instead. And just to, before I hand over on to Jaya, just to say that graph that I showed you before, best practice tariff, is publicly available, and the Daily Mail have run a story on a similar hospital in April on their poor performance. Handing over to Jaya.
So in summary, the key learning points, well, what went well? Well, we're getting the team briefing done at 8:30 or before 8:30. We've identified and are following through on the good to go patient. So that patient should be arriving in theatre in a timely manner. And we've now fully changed over to recording the patient's hip fracture pro forma electronically, which is a much better system. There are significant challenges, however, and Nick's already alluded to some of this. We have a significant issue with staff morale and engagement in the whole process. There are logistic and portering issues in terms of actually getting the patients down to the theatre complex, and the time in between cases is also prolonged, which reduces our ability to get more cases done. Part of that is also most likely linked to issues on the ward, so that patients aren't ready even when the porters arrive. We aren't meeting our best practice tariff. So, we're essentially not delivering for our patients as well as we should, and that has both financial and clinical repercussions for our patients. We're still not achieving 100% checklist despite the education and encouragement for doctors and nurses, juniors involved in clerking in these patients. And we're still only doing 3 cases a list on an all-day hip fracture list. So what would we do differently? Well, I think we need to address the core issues. We've touched on the periphery and we've picked the low-lying fruit, but we really need to, if you really want to improve things, we need to look seriously at how we assess the patients as soon as they arrive in A&E, the investigations that are done there. These are all national requirements that we don't do as well as we should. What happens with theatres having all-day hip lists run by the same team, that requires job planning and staffing to match that. We need to be very tough on list scheduling so that hip fracture patients and related types of cases are listed on the hip fracture list and not other cases. And then that leads then to discharge planning. So what's our next steps? Well, it's vitally important we now continue auditing our hip fracture theatre data in this way. And we've suggested that Dr. Mahmoon, who's shown a real interest in this, spends 1 week out of 4 every month collecting this data. And then we will have it in black and white to show where we are doing okay, but where we are failing. And I think he would be keen to continue this and do this as a regular mandatory audit. We need to continuously remind and encourage staff to complete the checklist and to ensure all the relevant investigations are done. Part of this comes down to staffing issues and the lack of overnight senior patient theatre coordinators, as Nick has already said, because of staffing issues, that so some of these investigations weren't being done. Therefore, that delayed things. We need to move on to the next part of the RPWI process and tackle head-on the challenges we face in terms of theatres. And we need to also start collecting surveys from patients specifically. How do our hip fracture patients and their families feel that the service they're getting is appropriate and adequate? And we should start collecting data as they are at the heart of this whole process. That's it. Thank you very much.
Great, thank you, Jay, and thank you, Nick. A hugely important pathway, really serious injuries for our patients, and just want to commend you for the focus and work to try and improve the timeliness of their surgery. I think for both report outs today, some green shoots and positive progress, but also some challenges, and I think that's point that comes through in both presentations about how we take people with us, how do we prepare the ground, take people with us and maintain that engagement, and then the importance of regular data collection to keep us accountable to what we're trying to achieve. So we've got time for some questions. I can see Jenny's got a hand up, so I'll bring Jenny in.
I thought both of those report outs were probably the best we've ever had, because they identify how teams can try and grapple with the things that are within your immediate control to grapple with. And it was great, if I see the things you managed to achieve in the fracture neck femur work, those were the things that were in your control to be able to do something about. And I'm partner the urgent care CSU for the Leeds improvement method, and I see them grappling with exactly the same issues. They're trying to use the Leeds improvement method within their own within the bits that they've got control, and they are definitely making improvements, but the big system constraints make that feel really difficult. So I guess my sort of observation is, one, both of you keep going, because keep going at the things that are within your control. But I'm also thinking, James, where does the learning from these RPIWs, is it the theatre board that we would want it to feed into? I'm just thinking about how we because they've both been brilliant report outs, and just for the reasons I've described, I think they're very, very powerful report outs. So I'm just thinking about where, Jaya, did you want to come in on that maybe?
Yes, thank you, Jenny. And Nick may have different views, but I'll tell you where I start. Does the trust have the ambition and vision to turn us from one of the worst performing trusts in the country to one of the best performing trusts when it comes to managing these patients? Because ultimately, if the trust doesn't, then all of this is not going to amount to anything at all. Everything we've done was to start the process, but the trust has to have the ambition and vision to say, this is no longer acceptable. We actually genuinely want to do something, because actually it hurts our patients. And I don't particularly want to see Leeds in the Daily Mail because we haven't done our job properly. I want Leeds to be at the top of the table, but that requires absolute starting, dismantling. There's no point putting a sticky plaster on this and that. You need to think long and hard, and this has to be a marquee process. This is what we're going to do. It requires difficult, challenging conversations with colleagues across multiple specialties, but this is so important. It absolutely trumps anything else. If the trust does, then we can change things around. I don't know, Nick, if you want to comment.
Only just to support that, and one of the comments we got on the colleague feedback was, reinventing this broken wheel will not work. This broken, just it needs wholesale change, and I think some colleagues, as we all know, will be intransigent to change, so I think if it comes from a trust board top down, right, you need to change this, no more, all the low-hanging fruit's gone, this isn't working still, this needs to change, sort it out, and then that process can start.
Thanks, James. So I think Jenny really hit the nail on the head when she said, well, people do make the changes, and the low-lying fruits can be had within your department, and you also kind of try and improve on, other higher fruits in your own department. But when it comes to getting engagement from other key stakeholders, for instance, in children's anesthesia, we're struggling with getting pre-assessment sorted out because it sits with another specialty, and this has been escalated right up to the CMO. So I'm not entirely sure how to address that issue without wider engagement from the Children's Hospital. So I suppose I could take it to the Children's and Young Persons Board and present it there, but essentially that might not be the priority for certain other CSUs, you see. So it's getting the priorities aligned with what the trust priorities are. It does need acting on from much higher up. And from CSUs. Thank you.
Great, thanks, Nalini. Right, I'll bring Jay in, and then Jenny quickly, and then I'd better wrap up because we're at time.
Just very quickly, there's also, we shouldn't forget that these changes will bring a significant amount of funding, certainly on the hip fracture. It's madness that we're losing up to £500,000 a year because we can't do the basics right. That would pay for goodness knows what extra bit. So the little bit of investment to really put this at the top of the agenda will pay huge clinical but financial dividends for the trust. I mean, to me, it's a no-brainer. But it does require that recognition.
Thanks, Jay. Jenny?
Sorry, I can't get off mute. So two things, I think we've got to be really clear how we particularly help these two report outs with the sort of the corporate decision making. So James, I don't know whether you and I need to pick that up with colleagues offline and sort of just try and close that loop. And then the other bit I would say to both report outs is, please, I can see in your faces how frustrated and demoralised you are, but just be proud of what you've managed to achieve and actually the conversation we've just had. So I know my ED colleagues are in a very similar place. So, you know, we've got to try and tackle some of these big system issues, but we have got to be clear, haven't we, the order within which we're going to do them. So, James, I don't know whether you and I want to touch base later today to just understand how this isn't my area, so I'm going to struggle to be able, but we need to somehow link this into a corporate decision making.
Agreed, Jenny, and I think we need to link in with the 2 exec sponsors for these, the Kaizen event and the RPIW. So Jenny and I will pick that up. What I'd encourage, as Jenny said, is don't lose heart. Do continue bringing your colleagues together around, you know, in service of this purpose. What you're trying to achieve is really important, and it requires action for issues that are outside of your control, and Jenny and I will try and support with that. But equally, it needs your teams on the ground to be engaged in it and to improve what is within your control. So don't lose heart, and please do continue to engage your colleagues in it. And we'll pick up. It's been a really good and really honest discussion in Report Out. And we will pick up and take away how we can lean in and provide a bit more support on the areas that require cross-organisational working and clarity on the trust's priorities. So thank you all. A great Report Out. We'll look forward to seeing you back for your 60-day Nalini and your 90-day Nick and Jay. And have a good Friday, everyone.
Bye.
Thank you, everyone. Thank you.